Insurance Committee will come to order. Susan, will you call the roll, please?
Yes, sir. Commissioner Carl Boyd.
Here.
Amber Brown. Brian Runyon. Holly Deering. Brian Gaither. Mary Hickerson. Lois Miller. Commissioner McAdoo. Commissioner Phillips. Shantae Sherrill. Michael Smith. Steve Spence. Sonia Stevenson. Eric Tutobeni.
Thank you, Susan. Now we'll move on to approval of the minutes. Has the committee or its vice chair had a chance to review the minutes? We have a motion. Do we have a second? We have a second. All those in favor say aye. All opposed? The ayes have it. The minutes are adopted. By acclamation. Financials, Mr. Elam.
Yes, sir. Thank you, Chairman Carr. For the month of February, I have revenue $1,798,820, expenses $2,746,406. The total for the year, calendar year, is $3,565,928. Expenses, $8,494,953. And your revenue less expenditures, a negative $4,929,025. For the fiscal year to date, you have $41,850,768 in revenue. Expenditures is $49,533,141. And revenue less expenditures, a negative $7,682,372. And I will remind you again, as you see the month of January and the month of February, the run out with the Board of Education, you again can see that it is on a negative side, but you're beginning to see where that run out is tapering off. For the 266 fund, you have, for the month of February, you have 0 workers' comp claims. For OJI, you have $44,158.20, and that would be your total also. For the year to date, you have $1,358,041.24 on workers' comp. OJI, you have $360,624.39. And the total for the year to date is $1,718,665.63. And that concludes my report, Mr. Chairman.
Thank you, Ed. Any questions for Mr. Elam?
Just one. Are we about where we normally are this time of year, Mr. Elam? Are we, as far as being up to date with our funds, are we about where we normally are, or are we more behind?
Are you talking about the 266 or the 264?
About both.
Or both?
Yeah.
Both?
Yeah.
The 266 fund, we are, we had an old workers' comp claim, and that was 1.3 million, so we're up there. As far as our OJI things, if that's what you're asking, we're a little bit on the higher side compared to the last couple of years. Keep in mind, with the OJI, the county has done additional hiring, so you have to look at actual hours worked. But I still think once you pull the actual hours worked, we would still be a little bit higher than what we were this time last year. 264, we will look at the run out. We're looking at now the county general, we're pulling all the data out of it, trying to look at where we are. I think we're really close on our numbers, very balanced. It's just that the Board of Ed run out is kind of added in there with it in the same, there's in the 264 fund you also have disability and other items more than just the medical fund. But we're pretty close.
Any additional questions for Director Elam? Seeing none, I'll entertain a motion in a second. We have a motion We have a second. Susan, please call the roll, please.
Commissioner Boyd? Yes. Brian Runyon? Yes. Holly Deering? Yes. Brian Gaither? Yes. Mary Hickerson? Yes. Lois Miller? Yes. Commissioner McAdoo? Yes. Commissioner Phillips? Yes. Shantae Sherrill? Yes. Michael Smith? Yes. Steve Spence? Yes. Sonia Stevenson? Yes. Eric Tutobeni?
Motion passes to accept the report. Director Elam, will you praise us of the resolution for absenteeism, please, sir?
Yes, sir. I wanted to pass this along to the committee. This was a resolution that was passed by the Fulton County Commission. I think the first one you have is the attendance. There is a in the resolution that applies to the insurance committee. If you have 3 consecutive meetings that you are absent, or 4 as a total in the calendar year, then you shall be replaced. And I read that exactly from the resolution, so just wanted to pass that along.
There is no action necessary with regard to this, but if you do have questions, we want to take those questions. You're recognized, Mr. Totobeni.
That go into effect?
It was passed on February 23rd, so I'm assuming it went into effect at that point, on the 23rd.
No additional questions? Thank you. Director Elam, if you'll debrief us on the restructuring of benefits and insurance, please, sir.
Yes, sir. So this was the final resolution that was passed by the Fulton County Commission. Very few changes from the committee. I will pass along one of the changes was on the vice chairman. They moved that to be voted on annually and for the month of September. That was in addition to what was passed through this committee.
Thank you. Again, there's no action necessary on the part of the committee, but we do want to take questions if there are any regarding. Okay. Seeing none, we'll move on to the OSHA report. Susan, if you don't mind.
This OSHA report is for February 2023. The total number of incidences was 23, which brings our calendar year-to-date total to 49. Of that 49, 33 were OSHA recordable, with 4 lost day claims, 22 restricted day claims, and 7 other recordables. On the next page, you'll see that for 2022, we were at 33, and 2021, we were at 36 for the same time last year, those 2 years. And then the next page is the incurred dollars. For 2023, we're at $193,000. For 2022, we were at $112,000. In 2021, we were at $140,000. And the last page of the 23 incidences, there was 15 at the Board of Ed, 8 at County General, and of those 8, there was 3 at Sheriff, 1 at Paws, and 4 at Fire and Rescue. And that concludes my report, Mr. Chairman.
Thank you, Susan. Are there any questions for Susan with regard to the OSHA report? Seeing none, I will entertain a motion and a second for approval.
Motion to approve.
We have a motion. Do we have a second? Second. We have a motion and a second. And I think we can vote on this by acclamation. All those in favor say aye. Aye. All opposed? The ayes have it. Thank you.
Can I insert something really quick?
Well, certainly. Do I have a choice?
It's up to you. You're chairman.
You are recognized, Mr. Elam.
So I just wanted to mention Susan was in a OSHA training class. We've been working on this for probably a year, a little more, to get her certification to be able to train our employees, and also it would give them a 10-hour OSHA card. So I want to say this in front of, on TV, so that's what we're working towards. We will be reaching out to some departments that we feel like needs that additional training. Once she gets her certification, then they will have that card, and hopefully it will reduce some of these claims and the severity of some of these claims. I think your last class is June, and hopefully she'll pass. She's passed all the rest of them, so. And then we'll be ready.
Mr. Elam, is there some cause for concern that the committee needs to be aware of?
Not that I'm aware of at the moment.
Thank you. Next, on item number 6 is the wellness update. Ms. Lovett with Cigna Wellness, if you'll come forward, please. Thank you.
Good afternoon. For the month of March, we have a total of 242 people that have completed all of their Motivate Me incentive points. And moving forward into the second quarter and for the month of April, we have a lot of good wellness activities going on. Starting off with our monthly podcast that will be communicated out on Monday because of the holiday. We usually send it out the first of Friday, so that will be going out on Monday along with the trivia. Next, we are going to open up our second quarter wellness challenge also on Monday, the Walk and Roll Spring Challenge. Please encourage your department to get involved. It brings a lot of great morale to the departments and obviously healthiness. Next, we have the physical activity class promotions. This is something new since I've been here that we're offering, and we're offering 3 different style classes for people to try in hopes that if everyone likes it, we might offer it more often. And lastly, we will be opening up a quarterly lunch and learn to talk about financial health going on into May or June. And that concludes my report. Is there any questions?
Yes, you recognize Mary.
Quick question, and Liz, I could have just asked you on an email or something, but do you have a rough estimate how many we should have on the, we've got 242 completed. What is our goal? What is the, if everybody done it, what is the goal right there?
That is a great question, and I know that we talked in prior meetings about trying to filter out the BOE, seeing where we were last year, and I will get that sent to you by tomorrow at the latest. And then I'll try to bring that to every meeting, just get that filtered out so we can compare last year's to this year. And also, I'll come up with a goal for each month. I would have to look at those numbers to compare so we can kind of have a better idea of a goal. So I'll get that to you, and I also will bring that moving forward to the meetings.
Okay, sounds good. I just were wondering what our numbers are with county general and the spouses that are on it. What a true number for here forward are we looking at of getting that? So thank you, ma'am.
Yes, ma'am, I will get that.
Any other questions? Thank you, Ms. Lovett.
Thank you.
It's not slotted. Lee Smith, I understand, I've been told, is going to present some additional information. Thank you, Ms. Smith, for coming up. My apologies for not being aware of that, but better late than never, right? Thank you.
Can I
hold
interject
on.
for
Yeah.
just a second here?
Director Elam, did you want to say something?
Yes, if you don't mind.
No, please.
So what I want to do here is, due to the events that have occurred recently, we wanted to provide this committee and at least get it on TV also, that our behavioral health programs and what we have available to people. So the next 3 exhibits that you will see, Lee's going to describe Cigna's part. I've asked committee member Stevenson to talk a little bit about the EAP life services, and then MedPoint's going to talk about theirs, what we have at MedPoint, to help our employees be able to reach out for any help that they may need, and just to give them an idea, kind of a little bit of the process of what they can do.
Thank you. You're recognized.
I believe on your screen at this point, you're looking at a program guide from Cigna. So Cigna offers all the programs on this page that address behavioral health issues at no charge to our current members. So this is just kind of like a little cheat sheet, if you will. You can use that to better understand the programs, direct people in your departments, and also just to point out that when you do go to mycigna.com and you're in a behavioral crisis, maybe you're trying to figure out which program you need, There is a questionnaire, so it's going to guide you to where you need to go. So that's what this is too. So, and then the next attachment should be your PowerPoint from Cigna. You'll have a title page, and then on the next page, I'm just going to make a few comments, and then I'll try to remind you to go to the next slide. So Americans overall need behavioral health support now more than ever due to COVID. We have 1 in 5 Americans that are experiencing mental health issues in any given year, so that's a very high number. 53% feel their mental health has been negatively impacted since COVID, and 30% have developed a generalized anxiety just maybe I have it, anxiety disorder since COVID. So this is key in light of a study that showed 70% of individuals with a medical condition also have a behavioral health condition in conjunction, and obviously we all know that that ends up with a higher cost share for our self-insured groups. So Cigna is going to engage individuals with behavioral health issues as well as those with undiagnosed and untreated issues. So if you want to flip to the next slide, that'll be page 3, and they are numbered. Cigna members can get access to virtual providers with a variety of specialties, including anxiety and depression, as well as providers who specialize in treating our emergency responders. And that's important because just in talking with some of the department heads and understanding not only the difficulty with these guys and their schedules and late nights and 3 shifts, just what they come in contact with, what they see, what they can't unsee. So that's very important. It's important for them to know, and all Cigna employees, that we're here for them. It's a confidential service with Cigna. None of the information that you share with us is shared with your employer, of course. Just like your medical, it would never be shared with an employer. So that's important to know. Cigna offers a lot of ways to get their virtual care. They can go to mycigna.com or call the number on the back of their card. They can always reach a provider, even right from mycigna.com. They can always reach out to Liz or myself to get more information on that as well. Cigna also offers tools and resources designed to help reduce anxiety and boost overall emotional health, such as iPrevail and Happify. On the next slide, it also shows that we offer support for parenting, childcare, adoption, legal issues, identity theft, and financial consulting if that's something a member feels like they need. And then on slide 5, just know that we're here to help you whenever you need it most, whether that be virtual, in person, pre-recorded monthly seminars with topics that touch on autism, eating disorders, and more. You can just, again, simply respond to the questionnaire online and find out which of those works best for you. On slide 6, we also assist members on their road to recovery from any type of substance or opioid abuse. And then we also offer pain management treatment or oversee their pain management treatment. On slide 7, coaching and support, again, as I've said, is available in a variety of ways. If you need help, we're here to assist, but most of you are familiar and have downloaded mycigna.com, so that's a great place to start. And then just again, to remember that all the services we offer are confidential. And that concludes my report.
Thank you. Any questions for Ms. Smith?
Yes, ma'am.
If a dependent or a minor child is part of your insurance plan, can they receive this counseling? Are there
Absolutely.
Are there special instructions? Does the parent have to sign them up if they're a minor, or?
I don't believe they have to sign anything. I can double check, but no, they shouldn't have to.
Like if,
And they also have, parenting and family counseling available.
okay, I was just envisioning in light of what recently has happened that there may be some homes that have minor age children who might need somebody to talk to.
Absolutely, and they can do that. And again, I did send an email out just to let Sonia and our department know that we were offering our EAP in conjunction with the county EAP, just in case anybody needs to reach out in light of what happened here in Nashville recently. Any more questions?
Yeah, Commissioner?
Maybe one, Sonia, if you could help me with this. There's a slide that deals with substance abuse, and the opioid crisis is something that is on everyone's mind.
Yes, sir.
And are you aware of what the county is doing as it relates to our opioid substance abuse committee? And is there a way to coordinate efforts between that committee? Is there a way that Cigna could be involved in that process?
So based on the meetings that I've attended, the opioid committee that I've attended, the funds are predominantly for those organizations who provide services that are basically nonprofit, a 501(c) or some other nonprofit entity. So I don't know if we have programs for our employees that, should they need them, as long as they self-report, I help guide them. If they've got insurance with the county, I get them connected with their resources through Cigna. If they don't have insurance through the county, then I help them with other resources. So I don't know if we could coordinate those, but I mean, I will look into it, since it's, it may be for somebody who doesn't have our insurance, or who maybe doesn't have the financial means to, even with insurance, pay the offset cost. That might be a good avenue, is to get a list of those individuals who are receiving funds from the county from that benefit. So thank you.
And I have been able to assist our current membership with, those maybe that are seeking in-network behavioral assistance or care, to find in-network facilities that are covered. Sometimes when that happens, or, it builds up, becomes an emergency situation, and we don't want to make snap decisions, and they just go to an out-of-network facility. So we work really hard to keep them at in-network facilities, where their insurance will give them more benefit.
Any other questions? Sorry, Ms. Smith. We're talking over each other. Thank you.
Thank you.
Director Elam, you're recognized.
Yeah, so what I have next is the Employee Assistance Program, which our vendor is EAP Life Services. And committee member Stevenson deals with them a lot more than I do on a regular basis. So I've asked her to kind of just give a description of what this EAP Life Services does for the employees.
Thank you. A lot of people have a preconceived notion that an EAP is just for those individuals who have substance abuse issues or going through family matters, but our EAP does so much more. Not only the Life Services EAP, but also Cigna's resources that they have available is more than just the mental health or the substance abuse. There's also some financial guidance that is allowed in this. If you'll look through your slides, the second slide has kind of a checkerboard of different things that they can assist with. Yes, it does help with those individuals who are maybe having substance abuse or anxiety or depression, but it also does some budgeting if someone is finding themselves having financial difficulties because they don't know how to manage their money. Estate planning, those are some of the ones. Also, they can have these services in a face-to-face, or they can do a virtual counseling session as well, and that helps for those individuals who work a variety of shifts. So the EAP is 24 hours a day, 7 days a week, 365 days a year. They don't ever shut down. And so those individuals who can't go into a predominantly office environment, maybe they're working, midnight to 7 or something, they can do a virtual appointment and still get the assistance that they need. Some of the other, we also have a member portal, and on that member portal, they can search any number of things. They can search self-help guidelines. Supervisors can go on that same site and search things to help their employees. Maybe it's time management, or how to telephone etiquette, or customer service, or if someone is having difficulty getting along with others in their office. So there's a lot of tools out there, not only for the employee, but also for supervisors in the departments that they have access to. And there are training materials that employees can use to enhance their skills on there, that they go through a training course, get a certificate at the end that they've completed that. So one of the things that we have used at the county as a tool, if someone is having maybe either performance issues or potentially inability to get along with others. Maybe they're going through something. When we do counseling, we can tell them that part of their counseling is that they must complete a course, and we'll go through a course that is specific to their whatever they're going through. And that's not to punish them, that's to help them, guide them, and give them some tools that maybe they don't continue on that same path. They can also get this from their telephone. There is an app, so it's quick, it's easy. They don't have to have a computer. They can do it from their telephone. They can call if they don't have a cell phone. They can call from a regular phone, and it has all different types of items on here. So they've got life coaching for work-life balance, goal setting, any of those number of things. They've also got some legal assistance. They'll get 30 minutes of legal assistance with a licensed attorney that can help with maybe a power of attorney or setting up a will or where they need to go for those type things, and they'll actually speak with an attorney. They do some financial assistance, helping someone navigate through if they're having bankruptcy, personal assistance with other, just whatever they need, kind of a concierge service of sorts. They can also be medical advocacy for those individuals who may have a disability and they're looking to file for a disability through the Social Security. So there's so many different things. We send out posters. They have webinars that can be done at any number of times, and they've got a leadership toolkit. And I will actually I've just been made aware of this, so I'm going to send this out to every single department head, supervisor, so that they have this. It's a leadership toolkit, and it has some warning signs, like if they notice something that they can help give guidance to their employees. And then also a training catalog that I'll send out. So that's kind of a high level. There's like tons of things that this program will do, but that's just kind of a high level.
If I
Anything
could
else,
ask
Mr. Reed?
a quick follow-up question.
Please.
Thank you, Mr. Chairman. You have a personal assistant, and it's got sports and recreation. Will they help me with my golf game?
If I could comment on that, I have not seen your golf game. I've heard of your golf game, and I think with great confidence that you probably need to search somewhere else for assistance with your golf game, Commissioner Phillips.
Well, actually, the personal assistant will find you a coach to help you with your golf game.
Excellent answer, Ms. Stevenson. Mr. Phillips, I think you found salvation.
This EAP program, is it just for full-time employees? We've got a lot of part-time employees who probably could benefit from a...
This is for full-time, part-time, retirees. It's also if any member is living in the household. So it is the employee plus their family members in the household, or if they have a child that goes off to college, they have access to this because their parents are included in this. So our volunteer firefighters have access to it. So, yeah, I mean, we've tried to make sure that those individuals, this isn't just for full-time people, it's for everybody.
Elected officials?
Yes, sir.
Thank you, Chairman Phillips. Any other questions? Seeing none, I think next is Amber O'Neill, Clinical Director for MedPoint, please. Thank you.
And Mr. Chairman, as she's stepping forward to give her report, I've also asked her to lay out what the clinic, MedPoint Clinic, has available for the employees too.
Thank you.
So at the MedPoint Clinic, just so everyone is aware, we do have behavioral health on site. The person's name is Tommy Shahan. He is a licensed clinical social worker. He provides services to a whole range of ages of patients, everything from young children all the way up through your eldest adults that will walk into our care. He also provides family services, couples services. He works with children with special needs. He works with people, he actually has a background with people who are going through kind of trauma situations such as long-term illnesses and whatnot. To highlight kind of a recent situation that happened in the clinic, we had a patient call who had gone through a very concerning behavioral health situation. And within that phone call, we determined a need, And within 2 hours, that patient had already gone in and seen Tommy and spent an hour with him, and then afterwards saw their regular primary care provider within our clinic to help back that up with some medication care. So we also have our regular providers available to offer some behavioral health type medications, such as your anti-anxiety medications or some depression medications and whatnot, and do that medication management in combination with the care that Tommy provides. So it's very comprehensive. And then some of, and I don't know what your personal situation is, but some of the EAP programs limit the number of visits that you can have throughout the time or issues, and yours may not, but some do. I will say that with our services, there is no limit. If they feel like they need to come and see Tommy multiple times within the same week, we can facilitate that. If they feel like, if Tommy wants to see them twice a month, we can facilitate that, and there's no end to that care because they've hit some benchmark. As long as that care is needed, they're there. I have seen him put on a tracksuit in the afternoon and go out and play with a child with special needs because that was his way of connecting with them. He meets them at their level. He does what they need so that they can receive the care that is needed for our patients, for your members. So that is available to everyone who comes into the MedPoint Clinic. And if there's an emergency, we can, provided any emergency status on our side, see them same day. And if it's not an emergency, we can see them very quickly. So this is not going to be I call in and I need behavioral health and I'm going to wait a month. That's not going to happen here. So just so that you're aware that those services are available here as well. And you don't have to have a special reason to see them. And you don't have to have a referral to see him. You just call in and say you want to see him. We'll get it taken care of. And we do not treat that patient any differently from the waiting room process to going to the back to seeing Tommy as we would any of our other patients. So it's not like there's some sign on them as they're sitting in our waiting room that, oh, they're here for behavioral health. Not that there should be a stigma with behavioral health, but we know that sometimes there is. They're not going to be treated any different than any other patient. They're going to be taken back. It's going to be private. It's going to be protected. And that information will always be kept private. So, all right, I will continue on with my report. So if you'll go to page 3 for your visit summary, New Salem had 168 visits in February. 142 unique members were seen. You'll notice that that was an increase of 42 visits over January, or 33.33%. So we're seeing that trend go up. We like that. Then if you go to page 4, on our visit by member type, we saw 24 children, 127 employees, and 17 spouses. On page 5, for our visit appointment type summary, 20 members had more than one visit in the month of February. 18 members had 2 to 3 visits. We had 117 established patient visits, which I know I've explained before, but that could be anything from sick care to medication management to just to check in on a chronic condition. We had 16 nurse visits, 16 annual exams, 9 new patients visits, 7 behavioral health visits, 2 telehealth visits, and 1 telehealth phone visit. On the multiple visits, they were a combination of sick visits and maintenance care mostly, though some of them were multiple types of services, such as receiving that behavioral health care along with some primary care services in there. On page 6, on our visit summary by day, there were 20 scheduling days in the month of February, and Wednesday was the busiest day. February had 1 less scheduling day than January, so it was nice to see that big increase even with 1 less scheduling day available. And if you see on the average patient seen, that it increased on every day except for Friday, and that Monday was the largest jump, where it jumps 4 average patients per day. On our in-person versus virtual appointments on page 7, we had 3 virtual appointments in the month of February, and of those, 98.21% were seen live in the clinic versus 1.79% were seen virtually. And on page 8, on our trending summary for virtual appointments, you can just see that the virtual appointment percentages are declining, and that's because we're continuing to trend towards in-person care. People want to come back. They want to see their provider in person. On page 9, for our referral summary, we had 36 referrals in the month of February. 6 were to gastroenterology, 5 to cardiology, 4 to otolaryngology or ENT, 4 to orthopedic surgery, and 2 to urology. So those were the top 5. On page 11, on our PEPM, in February, we had 142 total unique members seen, a total operating cost of $53,049.45, a total employee count of 1,960 for a PEPM of $27. This does still include some runoff from the previous clinics and the Board of Ed time and all of that. So it's not, I can't really give you a specific amount, but there is some runoff still in there. And on page 13, for our diagnosis codes, sinusitis, pharyngitis, and bronchitis, as well as encounter for general medical exam were the top diagnoses for the month. But that sinusitis, pharyngitis, and bronchitis was at 20.38%. There was lots of sick care in February. And if you can hear my voice, I could have been one of them. And 13.27% were for that encounter for general medical exam, which is really kind of that annual physical. So it's good to still see that as number 2, even with that sick care going on. Those rounded off with type 2 diabetes with or without complications being next, then anxiety disorder up there in that top 5 while we're talking about those behavioral health issues, and essential hypertension kind of rounding off that top 5 there. On page 14 on our visit demographic summary, in February, 55.69% of the members seen were female, and the female and male range of 40 to 49 were the highest population seen. I think this is the closest we've come to a 50-50 split between male and female in the clinic, so that was really nice. And you'll see there still was a really good span of age ranges seen, with 17 in that 10 to 19 age group category, all the way up to 5 in that 80 to 89 age group category. And on page 15 for our BMI summary, in February, both male and female, the percent of BMI was in the overweight category for the highest members seen. And I have one more thing that is not a slide to talk to you about, and I just wanted to take this opportunity to say that this will be my last presentation with you all. Beth Wilson, who's sitting back there, will be stepping into my shoes here shortly. And I just wanted to thank you all for the support and the partnership that we have had together with these meetings, with your questions, so that we can try to provide the best care we can for your members. Your support has made that possible, and I really appreciate that.
Thank you, Ms. O'Neill. Are there any questions? Yes.
Amber, for the capacity of the clinic, can you tell us what percentage of capacity we're utilizing now that we're a smaller and separate group from the Board of Ed?
So I don't have a percentage number on that for you today. We could certainly bring that next month. I will say that, we're seeing that average patient seen per day go up, but there's definitely still some growth room there. I did see that so far in the month of March, we're seeing that increase continuing. So that's a good thing. So we'll see the number of appointments continue to be higher yet again in March than it was in February, and I've already kind of confirmed those numbers and counted them out. But we're certainly not at capacity yet, for sure.
Mary, you're recognized.
I have a question on when we break it down and get to the per employee per month. Now that we're down to 2 or 3 virtual appointments over a month, is there any cost savings if we do away with the virtual appointments?
There really isn't any cost savings there to get rid of virtual appointments. It's really more of a convenience and utilization issue.
Anything else? Thank you. Thank you very much. Finally, but not lastly, Marissa Combs-Smith with Gallagher as Area Executive Vice President, will make her presentation.
Good afternoon. I see you've added a iPad, perhaps in my honor, given my last meeting. I did not have the computer, so I can track with you all. It's our pleasure to give our monthly report on your health plan budget options and some of the things that we're looking at together. We've had a number of internal meetings with the county admin team to evaluate kind of the things we've been talking about together. One of the concepts that you saw in your deck this month is actuarial value. So I'd like to take a few minutes to talk about that with you if possible. I won't read you what's in your materials because I know you've had them for a couple of days, but I'm happy to take questions about it and just really want to emphasize that actuarial value is how we measure or benchmark plans against each other. That's the gold standard in the industry. It's been really extremely prevalent since the Affordable Care Act was passed because it is creating those metal tiers for purposes of plan comparison in the exchange. So that gold, silver, bronze concept, that is, and y'all may not be familiar with that, but that is what is standardizing plan design, if you will, in a rating system that is uniform. So we're also using that at Gallagher. So with our actuaries, they're evaluating the actuarial value of the plans, both the state as well as your plans, and then bumping them up against each other. I also included in the deck some other resources that rely on this information heavily, just to kind of show you how prevalent it is. Examples, Kaiser Family Foundation. The Kaiser Family Foundation should not be confused with Kaiser Healthcare, which is another national carrier, not really operating in Tennessee, but more nationally. You might hear of them. Don't confuse KFF with that. They actually prefer to go by KFF now because of the confusion that was happening in the market, but KFF stands for Kaiser Family Foundation. If you are wanting to know kind of nationally what's happening in healthcare and that type of thing, that is a very good, neutral, bipartisan nonprofit organization that tracks and reports those things annually. So they are very heavily using AV value as one of their concepts. And then the Health Affairs publication, kind of the same thing. And then I provided for you also the Society of Actuaries slide that shows you kind of all the things that are taken into account with actuarial value. Now, why am I saying all of this? One of the things that we've heard from you that we do not take lightly, we think it's very important, is that when we benchmark your plans and the richness of them versus the state or any other program that might come about, whether it's a fully insured plan or a self-funded plan or a Blue Cross or a Cigna or United, or, I mean, it doesn't matter. Actuarial value is how we rank those plans. Richness is best determined that way because it avoids the concept of crosswalking or taking what's important, to one of us and prioritizing it above what might be important to the whole. So with that backdrop, Cigna's classification of actuarial value is what we are really trying to rely upon in evaluating your current plan and the way your members use it versus what they would get under the state plans. So working through those plans, I don't know which slide this is, but it's the one that says Cigna's calculation of AV, so I think it's 4N. The health savings account plan and the high deductible plan with the state are pretty comparable in percentage of actuarial value. Yours is a little richer, so yours is, in the battle of those two plans, yours would win slightly. But it makes sense that those are the lowest actuarial value plans of all three that we're going to compare because it covers the least amount right out of the gate, right? When we think of out-of-pocket maxes, deductibles, things that hit your members' pockets at the point of service, a high deductible health plan with an HSA is going to cost them money out of pocket quicker than one of the copay plans or something like that. So it makes sense that its actuarial value would be the lowest. Copay plan versus the state standard plan. So your current copay plan versus the state standard plan. The copay plan is the most similar to the state's standard plan. You don't really have a plan that's aligned right up with the limited plan that the state offers. So we have to compare copay versus standard and limited. But lest anybody think I'm being unfair about that, the limited plan is always going to be significantly less actuarial value than your copay plan because it's a tier below, if you will. Your copay plan is still exceeding the richness of the value of the state's standard plan. So the third plan that we looked at is your deductible plan versus the premier plan. Your deductible plan is sort of frozen, if you will, on enrollment. You don't allow new enrollees in that plan. It is the most equivalent to the state's premier plan at this time. And your deductible plan still remains richer than the premier plan, but just slightly. I think there's actually a typo on that bullet point because it was supposed to say than the premier plan on that last bullet point. All right, questions about that before I move to the next concept? None? Okay. So when we talk about what comes out from the state coming midsummer, one of the things we will reevaluate and report back to you on is how do the plan designs continue to stack up against your current plan design, or should we make recommended changes potentially to your plan design based on a variety of factors, right? Trend, managing risk, cost conservation, or aligning more to the state plans. Those are a lot of things that could be discussed as we move further. But so that actuarial value we just covered would be something we would update, in other words, based on plan design. And I want to show you why. So if you'll go to the next slide, which says 2023 state plan changes. This slide and the next really go through how the state altered its plan design between 22 and 23. Now, I don't have knowledge of how they're going to alter it or if they even will from 23 to 24. So please do not misunderstand me. I'm not saying there'll be significant changes. I don't know. That's the whole point, right? We're very much crystal balling it if we try to do that. But in fairness, to show you why I'm saying that, I wanted to give you something concrete to look at, which is to look back in time only for purposes of understanding more what I'm saying, which is in 2022, they made some very significant adjustments into 23, which shifted the point of sale, if you will, or what the member had to pay, which then in turn would affect the actuarial value of that plan. So let's go through some examples. Emergency room visits in 22 versus 23, they moved it from the concept of a copay mechanism and put it into the deductible out-of-pocket mechanism. So what did that mean? That means members can't just go to the ER and pay a copay. They actually have to consider the plan they chose and what the deductible and out-of-pocket consequence of that plan was. So I think that's a great change to make, so it's not a criticism. Why do I think that? Because when we know, actuarially speaking, that when people pay to go to the ER a set amount of money, they go more. It's just like doctors. If we know you're going to have a $20 copay to go, you're going to use it a lot more so than you would if you had to pay like $180 or something, right? So that same concept applies. The specialty medication change that they made was to take one tier of specialty drugs and divide it into two tiers. So in that instance, both tiers shifted the cost more to the member, but also it basically is like a change in formulary in the sense that your members, if they were on that plan, would have experienced a change in what they paid and what classification that drug was. So again, it's a richness of the plan issue because of more cost at the point of service for those on a specialty drug. So that one item wouldn't affect anyone who didn't take a specialty drug. Again, I want to be fair to not overstate the issue, just point it out what it is. The Premier Plan coinsurance issue, they moved 5% out of the pocket of the plan and put it on the member. So if a member bought the Premier Plan, they are going to pay 5% more of their point of service than they would have under the prior year. That's all that means. The Premier Plan deductibles also shifted. So again, this would affect actuarial value because it creates an opportunity for the member to pay more for longer and the plan to not pay as much for longer. So in 23, the deductibles shifted as shown on your screen from 22. So a family would pay the first $1,875 in deductible money as opposed to $1,250 under the prior year. So again, shifting that cost quite a bit. The standard plan very similarly had some shifts, but the standard plan, which again is most aligned to your mid-plan, your highest used plan, as a matter of fact, over 50% of your members, really closer to, I think 56% of your members are on that copay plan. So, that standard plan equivalent. So when we look at that, that would be shifting, in this instance, that would be shifting not only their deductible, but also their maximum out of pocket in the same year got shifted, okay? Now, am I saying those are bad changes? No. I'm just saying when we consider which plan's best, we have to consider all the factors, including actuarial value impacts from plan design changes. They make these changes typically. There might be some release of rate information in the aggregate, or even sometimes in more detail as soon as May. Typically, we have seen more detail come out in June or at the latest July from the state, where we understand more about rates, plan design changes, and then can, from that, extrapolate impact to plan. So, any questions about that? Yes, Sonia.
Marissa, the plan changes that were made in 2023, were those applicable to your statements where you said that our plans, all three, are just slightly richer than the various levels of the state plan? Is that after these plan changes were made?
That is correct. So we obtained this from Cigna. It was a January 23 actuarial value analysis, and they actually used two different methods to value it, and both methods resulted in the same response. The one caveat I do want to be careful to give, and I'm glad you reminded me to give it inadvertently, is just that the national, I think it's actually maybe was a footnote. Hang on, let me look. The official HHS calculator may slightly differ, but Cigna was using the knowledge that they have as both an administrator of the state plan and what it covers, as well as your plan and intimate knowledge to create those two methods. Mm-hmm.
So if I understand correctly, and knowing in advance that the premiums for the employees also went up from 22 to 23, that is correct as well?
That is correct.
So in addition to their premiums going up, the deductibles all went up as well, right?
Not every deductible. So I think we've called out the changes to the plan in their entirety. I'm not aware of another change. As I stand here, I could have forgotten something, but I'm pretty sure this was.
Well, I'm just saying, if I look at the comparison of the standard and the premium plan from 2022 to 2023, those deductibles went up as well as the employee's premium, correct?
The standard plan, yes, ma'am. Not only the deductibles, but also the out-of-pocket max. Now, I do want to pause and say, out-of-pocket maxes are rarely reached by the vast majority of your members. So again, in the spirit of fairness, and as we look at adjustments that can be made to conserve costs long-term, if you were to stay on a self-funded plan, or just like the state might consider this, as they have done, where they raise that out-of-pocket max, that typically, an adjustment of out-of-pocket max is typically going to really impact the people who are the highest users of the healthcare, so the sickest, the fastest, right? Because they're the ones that are spending more. So there is some thought, that you might adjust out-of-pocket max before you adjust deductible. Questions?
Any other questions? Okay.
So I think I just have one more
Please.
concept, which is the recommendations we're making currently, and we're asking for your support on, or at least your feedback. We're happy to adjust. You're our boss, and we serve at your pleasure. So these three items that are on this slide are our recommendations, and then we have some informational items I'm happy to go through if you have questions. Otherwise, we'll just let them be part of the slide. But the first recommendation is we would recommend that in order to get a true apples-to-apples comparison for this very important decision, we really recommend that this committee wait to vote until July. Why do I recommend that? As we've covered, we'll be able to give you a better picture of actuarial value comparison, of out-of-pocket maxes, deductibles, rates, all the things that would affect your members, and understanding how to use the coverage. So we're asking for that. That would then put the full commission voting, I believe, in August. So You would have that information in plenty of time for enrollment. Gallagher will support the enrollment either way through group meeting education and backup assistance to Mr. Elam's office in the way that we've committed to do. So it's not really putting us in a different position either way. And from a budget perspective, we have discussed this with your finance director and feel comfortable that this is an appropriate timeline. But we're taking comments and questions about that too.
I have, real quick, Mary, I have a question for Michael. I don't know if you are listening, but we're talking about pushing, explain again what we're pushing to July that you're requesting?
It is, lead with a comment. It's my understanding that this committee has interest in having a vote of whether to change to the state plan or to keep your self-insurance plan, but to actually call that to vote in this committee. Assuming that is true, I'm recommending that you wait until July to call that vote.
Thank you. I thought that's what you meant, and I appreciate that. Michael, to what effect, if any, does that impact our budget cycle that begins in July?
Well, a couple things. One, just because we vote in July doesn't mean we won't have some numbers that would come out in June from the state. So two options here. One, I think we could build into the budget whatever we could build into the budget some contingencies and some options in June, because we won't vote. I believe it's the last Monday or Tuesday in June that we vote on the budget. I believe it's at 9 a.m. historically. The second option is to look at, and we've talked about some options here, is we do have adequate reserves in the plan, because keep in mind, we already have the rate set for 6 months of the budget next year. Those are set now. So we're only looking for January January to July of 2024. So keep that in mind. If we were talking whatever percent increase, decrease, whatever that looks like, that's not a percent of the budget as a whole. So we would have time to pivot and some options there. So I do think this is a good recommendation. They did discuss it with me, and I do think it gives this body and the commission the most options to make the best choice.
So my point being, by waiting in July, it doesn't have any potential detrimental impact on our ability to move forward after July because we fall outside the budget cycle, correct?
It does not have any detrimental effect, no. And I just think it gives us more options.
Perfect. Thank you, sir. Mary, you're recognized.
Thank you. On this, we would be, you're asking us to wait to July, which only gives us 6 months of numbers to see. We know for a fact the first 2 months of this 6 months is already having some BOE run out in it, so they're truly not apples to apples there, because month 1 and 2 of the 6 months has run out on it. So I still don't see how that can, how we can make a very informed decision, even if February the 28th was the last day anything was paid on a BOE run out. 4 months is not a good, for example, of what our 1,700 lives of county general and those on the plan. I don't see how we can make a knee-jerk decision on that when other folks that have swapped his state took 13, 14, 15 months to do it. And we're asking to look at it in 4 months with 4 months of numbers that are not true numbers to me. And forgive me if I don't see it on here. I would think that in the month of March and April, for sure, at least April, that we wouldn't have some numbers of what would it look like for us 1,700 lives to stay where we're at, doing what we're doing. What kind of increase would that be on our premiums? I don't see that anywhere, and I don't want to make assumptions, but like I'd said several months ago, even before January 1st, we don't need to make a knee-jerk reaction, because it affects a whole lot of people, and there's a whole lot of moving parts to this. You pointed out 4 or 5 little divisions there of how the state looked like in 22 and what they look like in 23, and the premiums increase. So it needs to all be shown out, but we at least need to wait till July, but I want it known that we really won't even see 4 good months of numbers. You can't tell me that March is not seeing a little BOE run out. May not be much, but we need to know what our 1,700 lives is going to cost us, not what additionals are going to cost with us.
I think me and Ed both probably have something similar to
So,
say.
yeah, I'm getting eyes from you, and I'm getting whispers from Ed. Ed, I'm going to go to you first, then I'm going to go to Michael.
Okay, so first of all, try to clear up a little bit here, is that the statement is made about a vote in July. It's not necessarily a vote. What we're trying to do is to bring to the committee a comparison. If you don't want to change or move anything, there doesn't really have to be a vote up or down whether or not to go to the state. If the numbers show that it is better to stay with the self-funded plan, then you don't have to do anything, really. But the biggest thing is to be able to bring it to the committee and just to be able to make that comparison. As far as the run out is concerned, we will have the breakdown, and I think your numbers right now shows the breakdown of just county general itself.
That's correct.
So the run out would not be in any of these numbers and in the comparison as far as looking at it from the state plan. So it would be a true comparison of with those numbers backed out from the Board of Ed.
Michael.
My comment echoes what Ed was going to say, which was that I think it gives us more data. That's why we're asking kind of to push it to July, so that we can look at those state rates. Because right now, we really can't make any recommendation or really any true comparison because the state hadn't let us know their official rates. I mean, we can guess, get some hypotheticals behind the scenes, but I think Ed's correct. I think that way, one, we'll break out the numbers to not have the run out in. So we would have 6 months worth of just county data at that point. But two, we'll have the numbers in June, and then we will be able to compare that. My office and Ed's office can look at that and then bring and have a true comparison of what that looks like, so that if this committee and the commission were to feel that, hey, let's wait another year and a half, let's stay self-insured for 1 more year, or if we don't, we should have more accurate data in July than we would, let's say, in April or May.
Yeah, and I apologize for any confusion I caused. I think when I mentioned the call to vote, don't vote any sooner than July. That's really what I'm recommending. And I saw another question.
No, thank you. Mr. Tudabini, you're recognized. Please, Mr. Tudabini, use your microphone, please, sir. Thank you.
I'd love to. I think you already answered my question, but I wanted to take it a little further back. Can you back it up even further and simulate the last year, the last 18 months, back it out, and then that way you're getting a simulated comparison of 18 months instead of just 4 months?
Yeah, we're actually using, I believe, and I know Lois and my team have spoken even maybe more in detail, but I believe 24 months historical as well as getting actual currents, as they come available.
Yeah, because, for example, if you had 24 months where you simulated by pulling the county out and separating board and so forth, I think that would satisfy the concerns that you were having over there, right? Okay.
Yeah, I may have misspoken on how far back we were able to go and divide the data. So it may not be a full 20 months of divided data, but I do believe we have.
Would it be more than 4?
Yes, sir. Yes, sir.
Any other questions? Seeing none, thank you, Ms. Smith. Do you have more?
I have 2 more things we wanted to get feedback
my
from the committee
apologies.
on. No, that's okay.
I thought you were done.
Chris, can I ask a question real quick? On the first recommendation that you've got here to wait till July, do we need a recommendation from this body for you? Or Michael, do you think we need a recommendation from this body to move that? Normally we have these rates and ready to vote on in May, so.
I don't think it requires a vote or any official recommendation. It is, as long as we didn't object, I think us not voting this month or not voting next month is sufficient, would be my recommendation.
That's correct. And also in transparency, I wanted to bring to you that we are studying this. We've moved along and then came to the place where we felt like we weren't in a position to say one way or the other definitively what we would project for next year at this moment based on data. So, you know, as a result of that, I don't want to stand before you every month and have y'all going, when is she going to do what she said? You know, I wanted transparency in that process to say I'm asking your permission to bring that fully analyzed in that later meeting if that's acceptable to the committee.
Okay.
All right. Also wanted to talk about shopping the pharmacy. So prior to us becoming the broker for the county, the prior consultant on the medical plan had suggested that you all do an RFP formal process to evaluate pharmacy spend. We tend to agree with that. So when we're looking at your pharmacy claims, knowing what a tremendous amount of spend that is as a part of your total plan, looking at the claims history and that type of thing, and using our experience as a broker, we believe that it's time to shop that and just benchmark kind of what other programs would result in terms of savings. But I want to be careful to also say to you that just because we shop it doesn't mean we are changing it, right? So what may happen is we look at that and then say, you know what, based on formulary differences or based on just realignment of contract terms, you know, we're recommending this versus that. So in other words, it's a look, it's not a buy. So I'm just recommending that we go through that process. It would require a formal RFP that was already issued previously, but when the schools made the decision to break apart and go to the state, that was suspended. So really, I think we could have seen some savings now had that happened before, but you know, we're just behind a little bit on that. So we're recommending that we resume that work.
Ed, does that require a motion to?
I don't think so. But
Well, if you're wanting to do an RFP, do we have to vote on that, or?
I don't think so. I mean, we just want to bring it before you, and if there was an objection, then we would, you know, if there was a motion to do something different, then that would be fine.
you know, if there is a move to the state, you're going to have a disruption in formulary. So we felt like it's really only fair to consider what other things might be out there before we get to that point, or if we get to that point. So, yes.
I have a question. Help me remember, our pharmacy is part of the Cigna thing. Is there a renewal date that we need to have this information by, and we either allow Cigna a renewal agreement for the next year or ever how long it goes? So what is our deadline on getting this RFP back? And would it be that Cigna, and you may not know this, and I'm not sure how it works, but would Cigna be standing there with what their current plan is, or would they be able to bring a statement or a book of business or whatever it would be at the time that other companies or vendors would come in with theirs for this RFP?
Great questions. I think I heard two, but if I don't get all your questions, let me know. The first one is contractually what's allowed or disallowed, and there may be, and probably are, changes to the overall contractual arrangement with Cigna and what the admin fees are and what the way that rebates would be applicable and all of that have to be considered. But that would be something we would consider as part of the overall pharmacy evaluation. So if we were to recommend something, it's going to contain in it the implications of whatever was required from the Cigna contract. Second part of your question, I think, was, would Cigna be given a shot? And absolutely. In fact, we would expect that they would seek to retain this business on the pharmacy part, and we'd expect a bid from them. We'd invite a bid from them, I should say that way. So, all right, any other feedback on that one? And I can move to the last one. The last recommended item is that we extend the clinic contract, the county extend the clinic contract through December 31 if amenable to the clinic. Why am I saying that? Your deductible plan year, all of that is aligning with that 1231. So to give your members the maximum opportunity to align those who are using the clinic, to align that with the decision they made of which plan they chose, it would seem to make sense to keep it through that amount of time. However, I can also make the argument, because I, understanding how referrals work, we just heard some reports, 25%, of referrals are coming from the clinic to specialists, presumably also within that Ascension network, St. Thomas Ascension network. So that's a pretty high percentage, I think. So, it's a decision I think that you all should consider. Doesn't have to be made today, I don't think, but
So the contract expires on 8/31/2023. Those people that have chosen an HSA account, it might have influenced them if they knew that it was going to end on 8/31. I mean, again, that's one of the things, part of business is, we have contracts and some things last and some don't, changes occur. But our recommendation is to give us some time to do a more in-depth study into the clinics, to extend that contract, which would, as Marissa was saying, it would end, and then they would be able, we would know in time by annual enrollment, be able to tell them by that time, what we're doing with the clinics, what the committee recommends with the clinics, and to for them to be able to go into annual enrollment and be able to make the change that they might need to make based on the changes we make with the clinics.
Have we had the discussion with Ascension St. Thomas on what it would look like cost-wise to be 4 months out of contract if we take it to December 31st? Would they be willing to go September to December 31st at the same rate that they've charged us up to August the 31st? Have we had that conversation? Because if there's not been a conversation and we're looking at the same money in those last 3 or 4 months, the exponential cost difference, if we're not under the same contract, may not be worth it. We may have to cease it at 8/31 if it's totally non-affordable for those last few months, if we've not had any type of talk or negotiation with St. Thomas to work 3 or 4 months out of contract before we make that decision.
I think an important caveat would be the word extend the contract. So I would not be recommending that you go off contract for medical liability purposes. That wouldn't be advisable, as well as a lot of other reasons, but really an extension of the termination of it. It would be expected that we would put out an RFP for a replacement clinic, whether it's theirs again or something else, effective 1/1, if you were to consider keeping a clinic. We have some clients that have a clinic who are on the state health plan, and so there's a lot that goes into that decision. I won't get into it today since we didn't have it on our notes, but you may, as a governing body who's considering what's good for your personnel, the insurance committee may recommend, and the ultimate commission decision might recommend to keep a clinic regardless of the outcome of the decision on the state health plan. So there's lots that goes into that. And so I think extending contract, giving everybody an opportunity to present their bids, and then also maybe entertaining different models of clinics, some that are independent in the sense that are not affiliated with another network, might be best, especially if you were going to the state but wanting to retain that important employee benefit. So lots of factors.
But have we had a conversation with Ascension St. Thomas on, do we have a feeling if they would be able to extend for a few months to make it a 12/31 termination or no termination? I mean, if we're going to shoot to 12/31, we'll be past the normal contract. So we've given somebody some heads up, and we've gotten good feeling that they might be receptive to extending it?
Yes, I do not want to put words in their mouths, but they're receptive to it. Yes, we have had meetings with them. I also have another meeting. It was supposed to be Friday, but they had to cancel it, so it's going to be next week again. But I wanted to get This is something I think that probably should be voted on by this. Well, I think it should be voted on by this committee. This is one thing to get it extended, and it would be one thing that would have to go to the full commission. Chairman Phillips, would you agree? It would go to the full commission to extend it to 4 months budget, and then the full commission to extend it for 4 months just to keep everything clean. So that's why it's coming before you now. If the contract runs out, then we have, in August we have no clinic, but that's if they decide not to. But I have a very good feel about extending the contract with the conversations we've had.
I'm just curious, when you brought up the referral percentage at 25%, and you felt that was a little bit high, a little bit of background. When we first put the clinics in, we put them in specifically to save money, to do a trend bend, and if the referrals are running higher than you expected, which is funneling more claims over to Ascension, are we still looking at the clinics as a savings tool?
Yeah, I am undecided on that. What I will say is when I sat there today and heard the number of total visits versus the number of referrals out, I had pause and I calculated the percentage of the referrals isolated to the month of February. It may be an anomaly. Maybe when we do that over a 12-month period or a longer period, it actually doesn't impress me so much. So I'm glad to clarify, I'm speaking specifically about the February report that was just given. So I've got a note. One thing I'm going to go back and do is track not only PEPM historical. Obviously, we're going to have to shift our thinking because it's a new PEPM model, so it's going to be this new month of February really starting that tracking that we'll do. I want to track that. I want to track the referral rate, which is about, like I said, it's a little over 25%. And then I want to track their capacity and what's being done around the capacity. I think that continued promotion of the use of the clinic by HSA members is going to be good long-term if you intend to keep the clinic, because they can pay a fair market value to use it, and the fair market value is, I think, roughly at the moment calculated at $30, I believe. So really understanding how many of those members understand that and are using it is another piece that I think should be entertained over the next few months to get a true picture. Because we do think, I can tell you, it's zip code driven. Not too far up the road from y'all, we have a clinic where the average cost per visit in that community by zip code is roughly $200. Also, they have a deficiency in the number of primary care providers in that area. So we're seeing quite a bit of savings from the use of the clinic because they're not leaving work to drive to Nashville to see, there's a lot of factors, right? So to consider the overall savings, to directly answer your question, I think that it would be very unlikely for a health clinic that is back on our actuarial value discussion. It's actually another benefit that is increasing the value in your members' pockets, right? It's not counted for in AV because we're just comparing plans when we calculate AV, the actuarial value, but it's another thing that's making it richer because they have that option. That is a unquantifiable potentially benefit in the sense that it might not save the plan dollars, but if it's a richer benefit that your members value, then that's great. And I do think you're having some success with trending those numbers up. And as a percentage, the number of visits is actually, of your members, I have a feeling it's going to be high when I go back and do all that math, which I'm going to do. In other words, for 1,600 people to be using, on a county government, using the clinic 143 unique visits in a 20-day operable clinic month, I don't think that was a bad number. Just anecdotally, I want to study it better. But in terms of driving cost, if a Ascension clinic is referring primarily to Ascension specialists, then I don't know, maybe that's driving cost. We just need to study it. But whatever your rate of average office visit costs is, would be something we'd want to factor into that because you're saving that office visit for every one of those. So that's something that I think we can get with Cigna and kind of quantify a little better. My last study of this was $200 a visit. That's a lot. So. Plus the hours off work, all the things. Yes.
This is probably going to be an off-the-wall question, but, and sorry, so I'll apologize first.
It's fine.
That's how my brain works. But somebody could go to a clinic today, let's just say before it was Ascension, that it was one of our other MedPoint providers, and that wasn't associated with a facility. They could have easily gone there, and one of their clinicians said, hey, this is, we've run your labs, we run your tests, you really need to go get this checked out at XYZ, any one of those things. So I guess my question would be is, yes, they may be making referrals, and I too said 25% is a lot. Is that helping us on our MedPoint claims? Value. But the point is if those individuals are sick and they're referring them out because they do need care, do you have a way to say what would that have cost if we didn't have the MedPoint clinic and they referred them somewhere else?
Yeah.
Like somebody else referred them somewhere else. Does that make sense?
Yes, total sense. And I think, so it's important to me that I present a fair analysis. The same thing would happen if you had a Vanderbilt clinic, right? You're referring to Vanderbilt providers. And so this is kind of a universal truth of clinics, but there's also models where those clinics are not owned by the county in the sense that they're not your employees, they're a third-party contractor, but they're spun up by an organization that owns a standalone clinic that's not affiliated with a particular network. And I believe there could be potentially a difference in the way that those are treated. Now, having said that, I have also heard stories of because my employer has a clinic and I was able to go, especially if part-timers are eligible to go who are not benefits eligible. I think this is a huge benefit for those people, potentially, in the model I mentioned where it's a standalone and you own it and that kind of thing. Because you can say retirees or part-timers can go and their family members, commissioners, their family members, those types of things. And early detection is really, really important to saving long-term costs and quality of life. So I've heard stories. One most recently that shared with me was they put in a clinic, and in the first batch of people that started using it right after, we put in this clinic I was mentioning, the most recent one, someone came in, their throat had been bothering him, and he had early detected throat cancer. And that was a referral, right? So I'm not bashing referrals at all. I mean, sometimes that's really necessary. So.
Yeah, and if I could interject, a couple of things. One is sometimes people just need to know where to go. I mean, so that's their first step to get their primary care, to get to a clinic, and some can't get into the primary care doctor, so they say, I just need somebody to tell me where to go. So there are going to be, no matter how many clinics we have, how long the clinics are open, there's always going to be some referrals. And I will say, I do know, based on some feedback that our office has gotten, it's not just Ascension that these people are being referred out to. There's some specialists that's not even within the Ascension ranks that you have to move somebody to say, hey, here's where you need some help. The other thing that I will mention in the extending the contract to 12/31/23 is that the benefits rates are done on a calendar year basis. So Commissioner Phillips would be interested, when the amount was put in for the clinics, it was put in for the entire calendar year, and the reason for that was because if we extended their contract, it would go to 31, and if we extended it even a year and a half, 2 years, or did another RFP, we would need it in those rates for 2023. So the extending the contract is not changing the money as far as for commissioners. It's not. It's already in there for the entire calendar year. Is that a motion?
Does it need to come out of this committee, or can it come out of your department?
Yeah, it can come out of my department. I mean, that is my recommendation, is to extend the contract to 12/31/23. But I do think, and the money is already in there, so I don't know if it even go to the full commission. It may just go to budget just to agree to extend it, because it's not a monetary change.
Well,
The
if I may,
authority to spend the money.
if I may interject, if it's going to go to budget, it necessarily has to go to the full commission at that point. You don't go to one committee and not go to the full commission. That option's not available, as I understand it. Is that correct, Chairman Phillips?
Absolutely correct. I'm also thinking, can't we just decide to do it here, since it's already in the commission budget? Can we just decide to do it
The
here?
answer, to my understanding, is yes, we can.
Then I'll make that motion.
Okay. Can you make the, for the purposes of the minutes, can you define the motion, please?
Motion
It's
to
okay, Susan,
extend.
do you,
I would like
do you
the
have that?
record to
Thank you.
reflect.
Contract from August through December.
Oh, I was
Perfect.
hoping I could get agreement for everything I said.
So we have a motion.
We have a motion on the floor from Commissioner Phillips. Do we have a second to extend to the end of the year? So we have a second from Mary. This is involving money, so let's do a roll call on this, so we're dotting our i's and crossing our t's.
Yes, Mr. Chairman. Commissioner Boyd,
Yes.
Brian Runyon, Holly Deering, Brian Gaither, Mary Hickerson, Lois Miller, Commissioner McAdoo, Commissioner Phillips.
Yes.
Shantae Sherrill, Steve Spence, Sonia Stevenson, Eric Tutto-Benny.
Passes. Thank you. Chairman Phillips, thank you for that very much. Marissa, are you complete, or do you have more? I mean,
I serve at your pleasure, Mayor and committee. There are some informational items we did not discuss. I'm happy to answer any questions.
thank you very much. Is that it? Oh, Mary, I should have known.
No.
Mary, no, Mary, you're recognized. Thank you.
I have a question, and it's not, based on what we just passed, because we're doing the extension, would the contract not have to be signed by Mayor Carr for the extension? So would it not, I mean, this is something y'all can figure out, we've passed it. Would it not have to go to budget for full commission for someone to sign the extension of the extra months?
I'll review it again. I think it's a 3-1+1.
I think it was.
If I'm pretty sure it's a 3-1+1, so, yeah, with a 90-day out clause, if I'm not mistaken.
Mary, if we find out something different than that, then we will absolutely bring it back to this body and make sure that we proceed correctly. I do believe that we have it correct, but if there anything changes, we will certainly bring it back here and get it to budget on the full commission. Anything else? Thank you, Marissa. Is there any other business? Seeing none, the chair will entertain a motion to adjourn. We are adjourned. Thank you.